different imaging tests may be confusing because there is not any specific lab test that we can use to say that someone's in pain, right? We can't justify someone's pain with a lab test. I think it catches patients in a difficult situation where they may have normal lab tests and they're told that you don't have any reason for your pain. How much worse can you get as far as trying to get any clarity on what you're suffering from?
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, and today's episode marks a moment I've been working towards for a very long time. When I launched this podcast years ago, my vision was to create a space where patients and clinicians could learn together, where complex, often misunderstood conditions like Ehlers-Danlos syndromes would finally get the thoughtful, nuanced attention they deserve. I'm incredibly excited to share that this vision has expanded in a meaningful way. Today, I'm welcoming Dr. Dacre Knight, formerly of the Mayo Clinic, who is now the medical director of the UVA Ehlers-Danlos Syndrome Center. The UVA EDS Center is officially partnering with Bendy Bodies, and Dr. Knight will be joining me as a recurring co-host twice a month. This collaboration represents a shared commitment to better diagnosis, better education, and better care for people living with EDS, HSD, POTS, mast cell disorders, and overlapping conditions. In this episode, we'll be unpacking why patients with EDS, POTS, and MCAS are so often misdiagnosed, and how clinicians can shift their thinking to recognize meaningful patterns earlier. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Make sure to stay with us until the very end for our hypermobility hacks and many more conversations to come. Let's get started. I'm super excited to tell you about the Bendy Bodies boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Okay, well, I am so excited to be back again with Dr. Knight. How are you doing today?
Doing well. Yes, equally excited to be here.
Excellent. Oh, I'm so glad. So today we're going to talk about the challenges that people have with getting a diagnosis and why it is so hard for people with EDS, POTS, mast cell activation syndrome, et cetera, the what we call often the Triad, why this is so hard to untangle and so challenging for both patients and clinicians, really, don't you think?
Oh, yeah, totally. And it really shouldn't be such a challenge. I think we can identify some of the major gaps where there are things that fall short, why it becomes a challenge. But yeah, and for reasons why it's a challenge for patients, then it makes it a challenge for providers and vice versa. So, all that we can do to educate others, which is, I know what we're doing here, will be all to the benefit of that.
Absolutely. Because, so many people think there's nothing that you can do. And I don't know about you, but I find that so frustrating because that's not true, right? There are things. And so we're going to be talking about treatment you and I are going to have another great conversation in a couple of episodes where we're going to be talking about treatment. But today we're going to be talking really about diagnosis and working people up and things like that. And some of the, kind of big picture problems that we see. For example, I'm sure you see this also, people with EDS, POTS, mast cell related symptoms, et cetera, they're often labeled as complex, anxious, and or functional. Why do you think that happens so often?
Well, that may be, I guess, we're saying, where are we falling short? That may be one of them, because is the perception that patients with these conditions are too difficult, and providers would simply just wash their hands and say, I don't want to bother even attempting to try. And as you pointed out, they may not even make a diagnosis or attempt to make a diagnosis, they may say that I hear it all the time, that there's no reason to make a diagnosis because there's no cure. So what's the point? And it's horrible. Truth be told, the reason why these cases become so complicated is because they've just been pushed aside and they haven't been addressed head on. And so every time that happens, it just gets more and more complicated, right? Until someone's finally sitting with this, it's really big, complex case.
Exactly. I've often thought that too, that if we were able to diagnose people a lot sooner, a lot of those other sequelae wouldn't happen or they wouldn't be as severe. And also, by the time somebody's had, head pain or neck pain or abdominal pain or whatever for 16 years, you know, it just gets so much harder to tease out. Whereas earlier on, if somebody really did try to look under the hood and really try to look deeper, I think they would have more success. So yeah, that's why it's so great what we're doing here, and why it's so great what you're doing at UVA. I think that center is going to be so helpful for so many people. So it's really exciting.
Yeah. And we're talking about early on, I know we had a show with my partner here, Ina Stevens, a pediatrician, and why it is so critical to get these kids in who may be affected, and sooner the better, really. That's part of what primary care, though, is too, whether it's with a pediatrician or a family doctor or an internal medicine doctor for adults, that they are at the front lines of seeing patients who may be affected with any number of conditions, and bless them for all of those things that they have to consider, and the differential diagnoses that they have to come up with anytime they see someone who, may be typically in good health, but all of a sudden may not be, or may not even be sudden. It may just be kind of a progression of symptoms getting worse. And so they do have a very difficult job, but that's why we want to, again, educate as best as we can anyone who is in primary care, who may be seeing these patients, so they can identify it before it gets worse.
And I imagine you see this as well. People who they've tried Western medicine for a little while and then they're not getting anywhere. So they give up on Western medicine and they start. I'm not saying that everyone who's not practicing Western medicine is a charlatan, but they might end up trying some pretty crazy things, some very expensive things. Some of them are good and helpful and science-based, but sometimes they end up trying some things that are pretty far out there. And so that also, I think, complicates the picture.
Well, yeah, and why wouldn't they, right? If they're not getting anywhere and there's no progress being made, then I have no misunderstanding of why someone wants to continue to try to care for themselves, and really give them credit for it. And fortunately, it may be in the wrong direction, or they may end up with someone who's selling them some snake oil, but maybe they do get to the right place, or hopefully get connected to the right person who is knowledgeable. And it doesn't even necessarily have to be a clinician, really. It may just be someone that they has had similar experiences. So a lot of our patients are connected on social media and elsewhere. And yes, there's potentially a lot of issues with social media, but there can certainly be some good too.
Yes, yes, there definitely can be a lot of good there. So, what do you think medicine gets most wrong about the EDS, POTS, MCAS triad?
Well, I guess, and we're all learning. Really, we're all in this together to take an advantage from the COVID pandemic. But we are learning about these associations, and more so for recent years. And I know you had some excellent guests on this show that have talked about these, but some years ago, we weren't really thinking about the connection there. So I think what we still get wrong is maybe even still thinking about it. If we come in, have a patient who comes in, it's, all right, I've got EDS, or I'm thinking about EDS, and the first thing we think about is EDS. Well, okay, but what other symptoms do you have? And it takes time. And, is there potentially a role for another comorbidity? And yeah, we have to think about it. So I think where we go wrong is not really still drawing the associations and understanding exactly where the associations relate to each other as cause or effect. I mean, this is certainly an area ripe for research, but I'm hopeful that those answers will come with time.
I am too. And do you think our siloed healthcare system is part of that problem too?
Definitely part of the problem. And we could think of it a couple different ways. Uh, we have silos in one way because there are specialists who sit in those silos, and they're sometimes very hyper specialized, and that's good as our knowledge of medicine has expanded exponentially over many years of study. There is a reason why sometimes these specialists get so hyper focused in their field that they sort of don't look outside the box, so to speak. So there is good reason to have specialists and hyper specialists, and they can certainly add to the care of a patient if we need an expert on a very rare, unusual situation. But we do need also to have those clinicians who can act as a bridge and to break those silos, or maybe even if those specialists themselves are willing to explore and to think outside of their area, maybe they can sort of breaking down the silo effect as well.
Yeah, and I think that's something that a lot of people don't necessarily understand, that things are advancing so quickly that if you're not in a certain specialty, then it's hard to keep up within a narrow focus, right? Much less something else. So it's, to me, more important that you know what you do and don't know, and that you know to refer somebody out, or that you may just be open-minded to these other problems and say, well, let's explore those with these other specialists, rather than, guessing. Or, yeah, you probably see this sometimes when you're reading other people's notes, and it's like, oh, I wish they wouldn't have even said that, because I don't know their specialty. They don't know this niche that, you and I are in. The science can evolve so quickly that it's hard.
Well, it's so quick, and not just the science, but the technology and all the tools that we have are advancing so quickly. We don't really even know how to use them. What do we do with this information? But I think you're right. I think at the very least, we should think that maybe we keep these connections, we keep an open mind, and we keep learning. And drawing connections, and I think with time, eventually we can start catching up. Although it seems like the way technology and information is growing, I don't know if we'll ever catch up, but we can do at least our best to help patients.
Definitely. And speaking of helping patients better, I don't know if you heard this statistic, but it was something like within 3 minutes or 5 minutes of an encounter, the doctor already has like the full plan in their in most encounters, right? The doctor has the full plan in their mind. They're already like, in their mind writing whatever script they're going to write. And instead of like immediately making we need to be fast if we're in a regular conventional setting, right? And you have 10 minutes for a visit. You can't be taking an hour to do a 10-minute visit, because by the end of the day, obviously, you're going to be in a world of hurt. But we want to make sure that we're really looking for patterns, right? We're not just, checking off boxes, but we're actually looking at patterns. So when you see a patient who comes in with the common things that we see, right? So they have pain, they have fatigue, GI symptoms, maybe they have dizziness, brain fog, et cetera. Are there certain patterns in there that immediately catch your attention, and or that you want other clinicians to be aware of?
Yeah, that's a great question, because I think that's what we're evolved to do, not only as clinicians, but as human beings, to learn patterns and make observations of the world around us. And certainly as clinicians, that we do develop our own sort of internal algorithm with time. And, it's to the benefit of us, like you said, you're not ruminating over something for hours and hours and hours, so you can actually help more than one patient, and ideally, and also because when we have the experience of seeing multiple patients, there's going to be a variety of different presentations, right? And certainly with EDS, because we know, as we say, no two patients are exactly alike, and so we would it's altogether have a algorithm, so to speak, of knowing that there's something that is abnormal then. And really, the way I would approach it, and I still do this day to day, is that I just let the patient talk, and that's one of the hardest things for clinicians to do. And there have been studies on this, and you mentioned some of it as far as the things patients come in with, but I think it's just, I don't remember the exact time frame, but it's just a matter of within minutes, not just forming their own diagnostic opinion, but how soon it is before the clinician interrupts the patient. And it's just a matter of minutes. And of course, that adds to, they've creating this own, kind of idea of their own summary in their mind already, what it is. But, you know, William Osler famously said, listen to the patient, they'll tell you their diagnosis, right? So we really just have to let them talk. And that's where we start getting the best clues, and then I can start, recognizing some patterns and things there. But even still, we have to be very careful to be too judgmental or jumping to conclusions on any one pattern, really.
I agree. What about some of the common diagnoses that patients receive before they come see you when you were at Mayo or now when you're at UVA?
Well, okay, so the common, I guess, say presentations, and we see this across the board is in all the studies, but would be pain and fatigue. And I mean, in the order of, over 3/4 of patients. And it seems like if you really kind of go down to the minutia of it, that fatigue, although is very ambiguous, is probably the more common of them all. But pain and fatigue, and then headaches. These are all very common. So as far as diagnoses go, I mean, we have lots of things to be spread all across the board of what could be a diagnosis within that. But there's all of these conditions that we see, and you mentioned the trifecta and all of those that may certainly include pain and fatigue and headaches and uh, digestive issues, all of those other ones that are very common. As far as diagnoses go, whether it is EDS or POTS or mast cell activation, there would likely be a diagnosis when we're in our clinic. In my position of as an EDS center, hypermobility obviously is a close link to pain as maybe a cause of pain. And then that, as far as digestive issues, we very commonly see the IBS, functional dyspepsia, or now what we call disorders of the gut-brain interaction, headaches, all variety, but very commonly migraine type headaches, tension type headaches, and maybe some cervicogenic headaches when we're talking about cervical spine or musculoskeletal issues. So, I think that those stand to reason why those are the most common presenting issues.
And what about the people who have been, labeled, oh, it's just anxiety, it's just IBS? What are your thoughts on how that might delay meaningful care?
Well, yeah, I know a lot of your listeners probably have unfortunately had that issue of delayed care because uh, that is often the description that they're told. Unfortunately, it's all in their head, and then they really are at a loss. I mean, what can you do with that information? It's all in my head. Okay, well, how do I get it out of my head and how to get there? What I don't even know what that means. And it's not to say that there have been studies on this that, when we look at presentation of anxiety and depressive issues. It's not to say that some of those things might develop with time. And certainly if someone is being brushed aside as we're recognizing, and on this diagnostic odyssey, I mean, who wouldn't have some mental fatigue, at least with all that and all the repercussions of it, whether it's anxiety or depression and things like that. So the challenge lies, as I mentioned, if it's not addressed correctly, we're not making the diagnoses correctly, we're not getting the right treatment and prevention started, then it's just adding to the chronicity of the illness. It's it's just making it be there longer, and then it's going to take even longer to improve from. It's adding to the complexity, the other comorbidities that develop. So, someone being told that it's just anxiety, it's mistreatment. It's malpractice, in my opinion.
Yeah, so many of us with EDS do have anxiety. I mean, I definitely have anxiety. But that doesn't mean that anxiety explains everything that I'm feeling in my body, right? So being told that it's just anxiety, and I don't know if you have seen this, but I feel like gaslighting has become more and more common, even with people that don't have EDS. I was at an appointment not long ago with a family member who is also a physician, is a white male, So, has like everything going for them, like super fit, like, all the best possible chances of getting good quality care. And the care overall was fine, but the orthopedic surgeon literally looked at the person's knee MRI and said, "My knee's worse."
Yeah. Those kind of discussions, like, I mean, why, as my grandmother would say, if you don't have anything nice to say, don't say it at all. I mean, if you don't have anything helpful to say, don't say, because that's certainly not helpful.
Yeah, yeah, I was kind of floored by that. And the person, it was an orthopedic surgeon and turned out to be an excellent surgeon. But that kind of a comment is like just just kind of blew me away. And speaking of things that people say and that can be also though misinterpreted, functional neurologic disorders. I feel like this is an area that's really challenging. Or functional. There's other functional disorders, right? Functional gut problems, etc. Functional is just supposed to mean related to function and not structure, right? So it doesn't mean, although it sounds like, oh, it's in my head. There is there a place, I guess, is what I'm asking. Do you think there is a place for using those labels?
Well, I think this is also a good question because it causes us to look at our medical practice introspectively. What are we doing, and what do we learn from that? And really, as much as we know, there's still lots of black space in outer space of medicine, and that's usually where these functional conditions get lumped into. We haven't identified it yet. It's sort of a placeholder as the science improves. And is that good or bad? I mean, it's bad in the case where it's a misdiagnosis, right? It's missing an opportunity to find improvement and treatment. But maybe at least it's good in a way, and I'm really stretching here. At least we're identifying something's wrong, rather than, you know, you being told that my knee MRI looks worse, right? But at least we recognize that, there's something wrong. So that's a start, but I'm being awfully generous here. In any case, uh, you know, do they have a role? I think the answer is that yes, there is a role still for unknowns in medicine, and there's a lot that's still unknown. We want to answer the unknowns and answer those questions and solve those mysteries as best as we can, but it takes time.
I think that you're right that some people will prematurely jump to that conclusion. Oh, it's a functional, neurologic problem, and then not offer any treatment. I've seen, as I imagine you have, so many people that have been labeled with that and then offered nothing. It's like, okay, well, what am I supposed to do with that label then? What am I, what am I supposed to do?
Yeah, and you probably see that those patients may be even more confused than they were to begin with.
Right. I did have one patient who, as I was reading through her chart, she was getting progressively, more challenged in her ability to walk. And so I thought by the time I saw her, maybe she was going to be in a wheelchair or something. And much to my shock, she walked into the appointment and she seemed actually quite good. So I asked her, I said, "What happened? Like it sounded like you were progressing towards using a wheelchair." And she said that she was diagnosed with a functional neurologic problem, and she was sent to a specific physical therapist that specializes in that, and it really worked. The physical therapy that this person did really worked and really helped her regain strength. And I don't know how that person's training is different or what they did was different, but anyway, that was kind of interesting because I saw so many other people labeled with functional problems and just left, just abandoned. But this one person who got connected with care that was really beneficial for her. So that was good.
Well, that really is, that is awesome to hear, and I love those stories. Not only is it, it gives you a warm feeling, it makes me smile, but I think that we learn from those, right? As how we practice. And what I learned from that is, and you're right, we may not know exactly what this physical therapist do or specific technique, but I would guess that they have gotten some familiarity now of their own kind of algorithm and recognizing patterns, and they probably see that the patients come in, um, certain things have been ruled out. They don't need to waste time about discussing brain MRIs or whatever, and they can get geared into treatments more, and they may know that some treatments work better for certain groups of patients based on their presentation. So I would venture to guess that they become well adapted to that. So that I think that's telling as far as the potential that is had, and just like we were talking about earlier about, you know, providers may not want to see EDS patients because they're challenging and things like that, but maybe they're challenging just because they're not seeing them, right? And they haven't allowed themselves the time to develop these patterns and algorithms and know what to do. And so I love these stories, and I would, propose and I always like to do is share these stories with patients as well to give hope and inspiration that on this show that we probably highlight some of those stories and, go over through the process of what actually it was that made these patients better because we, certainly do want to inspire hope.
Yeah, I sometimes I find myself this happened just a couple of days ago. I was seeing a client for coaching, just for a virtual, conversation. And I'm thinking to myself, oh my gosh, I have this one patient who, your stories are so similar. You're kind of going down a very similar pathway of, workup for pelvic venous disease. And they had been seen at the same clinic for these problems. So I wrote to the patient and I said, would you be willing to talk to this other person? And she was like, absolutely, I'd be happy to, because she was much farther along in her journey. And so I think you pointed out earlier about social media and how people can really use that to be beneficial. I've had that happen a couple of times where I've had one person that I thought could really benefit from talking to another person. Of course, you have to get their permission and all of that. But in one of those cases, it was my very first patient that I ever saw, and I wanted her to talk to this other young person. I said, or if you want to write something down. And then she wrote down this beautiful thing. And I said, well, we should probably publish this somewhere. So we published it on Kevin MD. And then that led to another thing. And that led to me ultimately interviewing her on the podcast because I was like, wait, we should have not just one person listen to this. But yeah, so I think that you're right. I think that these kind of stories really help us keep that hope alive, which is critically important.
Well, absolutely, and I know you know well. I've sent you patients as well who I've had, and it's they've got some long history of dance or ballet or something. And they got EDS, and I know that like we are talking about, we're getting hyper specialized. So there is someone who's specialized in EDS who's got an understanding of dance and ballet, and so yeah, I appreciate that, and those connections are certainly valuable and. I've noticed the same thing that you have, connecting patients, and I know the EDS Society, and we have tried to act on this as well, as far as like health advocacy programs and patient advocacy, and we have a patient advisory group that helps inform us of the practice, and what I've learned through working with them, and I've given some talks to the EDS Society's health advocacy program, is that it's very good for patients to be involved in this, as it really is almost part of their care journey. And as far as their treatment goes, is we say in school, like one of the best ways of learning something is by teaching it, right?
Right, right.
And all through medical school, we were trying to teach each other various things, but yeah, it's helpful, but it's also helpful to us. And so as patients, teaching others, it's definitely valuable part of their treatment experience. And I'm sure we could have a full episode on social media because, yeah, you're right. There's definitely some good to it and getting people connected. And my ideal world is that there is some platform somehow that patients can be connected, because I've got some very knowledgeable patients I could think of in many occasions where they would be excellent resources for certain other patients. And patients are eager to do this. They, here's my information. Let me, link up with anyone I can help. And I'm so appreciative of that. It's hard though, when you go into social media, it's just kind of like the Wild West, right? And
Yes, yes.
it just gets derailed so quickly. And is anyone maybe as gregarious as they may be, they just get sidelined, right? And so it's very difficult. But I would love to be able to nurture that some way. And I know what we're doing here with the show is at least trying to get the message out there. But I know that sort of that personal connection between others is so critical too.
Yes, yes, it absolutely is. And I'm glad that you brought that up because I think talking about social media on a future episode with you and I is a great idea. And I do also want to mention to everybody listening right now that we are going to be addressing all kinds of listener questions. So, please send in your questions that you want, Dr. Knight and I to answer because we're fortunately going to be having these conversations a couple times a month. Sometimes it'll be just the two of us. Sometimes it'll be the two of us with a guest. So we're going to have some great opportunities though to answer your questions. So they could be about, anything. So go to bendybodiespodcast.com, submit your questions there. And the team does a great job of, bringing ones to our attention that are like, super, super great to answer. So we'll try to get to as many of those as we can.
Definitely looking forward to that. And I see it on a regular basis in my clinic that we're discussing plan of care with patients and do you have any questions? And it's almost like, deer in headlights. I know I do, but, wait till I leave and I go home and I'll think of all the questions. So yeah, this is a great opportunity to get those questions out there.
And I don't know about you, but I find that I'll sometimes answer the question a little bit differently on one day versus another day. And so sometimes, even if it's a question that's already been addressed, hearing a different explanation, or you probably are going to explain things, differently than I am. So I'm really excited about this collaboration and getting the opportunity to hang out with you.
Yeah, well, certainly I've learned a lot already and I'm very excited to learn more and share more.
Great. We're going to take a quick break. And when we come back, we are going to talk about what clinicians tend to miss and some takeaways for patients and clinicians. We're going to take a quick break and we'll be right back. As someone with EDS and who treats patients and does lots and lots of these podcasts, I am always looking for products that are going to help me be more comfortable. I want to tell you about Cozy Earth. There is nothing more comfortable than getting into a cozy bed and making being at home the very best part of your day. Cozy Earth is so confident in their products that they actually offer a 100-night sleep trial. This is insane. If you don't love their sheets, after a whole 100 nights, you can actually return them hassle-free. And they also offer a 10-year warranty. That's insane. A whole decade. So start the new year off right and give your home the luxury it deserves. Make your home the best part of life. Head to CozyEarth.com and use my code BENDY for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here on the Bendy Bodies podcast. Give the gift of comfort that lasts beyond the holidays and carries into a cozy new year. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we're back with Dr. Knight. We're going to talk a little bit before we get to what clinicians tend to miss. We're going to talk a little bit first just about the triad and if that concept is clinically helpful or if sometimes it tends to oversimplify the reality, which tends to be even more complex than that. What is your thought about the EDS, POTS, MCAS triad?
Well, it is an interesting triad, of course, because we're looking at very disparate things at on first glance. We're looking at, cardiac, neurologic, we're looking at tissue, musculoskeletal, and then we're looking at immune, potentially autoimmune things. And, how in the world could these potentially be related? But as we would also say in connective tissue disorders, you really can't rule it out. It's connective tissue is head to toe. So we really have to think of every system.
Right.
And when we talk about systems, these are, these are the largest systems in the body. So it's not too surprising that they may be connected. And downstream of that, they may involve other large systems, gastrointestinal systems or urogenital systems. So, that's my initial thought is like, these are wildly different, but also very big and very closely connected. And so I think, what would be the natural course of doctors' thought on it is that how do we potentially link these up in a way that treatment can approach at least two, if not all three? And that's ideal for everyone. It's ideal to the patient, costs, it's ideal to the provider of having less balls to juggle at the same time. And usually that's what we're taught in medical school, Occam's razor, right?
Right.
Don't add to plurality if you don't need to. More things likely related to one than multiple. And so, if we can tailor treatment in a way that kills two birds with one stone, then that's awesome. And that's what I would like to do, and that's what I think is best for patients.
And I'm so glad that you said that because I think so often, people have gone away from prescribing opioids for chronic pain, but I still see some very young people on opioids, and I'm not saying that they're never appropriate. Sometimes they are, but so often you end up with prescribing the opioids and then they get constipation and they get nausea. So they end up getting a prescription, for Zofran to offset the nausea. That makes them more constipated and it gives them a headache. And so then now they need something else for the headache. And so I couldn't agree with you more that if we can address the root cause, whether it's the mast cell or, some other process that's going on, we have such a higher chance of success because otherwise we just keep playing whack-a-mole and we keep adding other things to just, mitigate the damage from the from the things that we're doing.
Well, and that's truly an internist or a generalist's biggest nightmare. You see a patient who's got a medication list that's a mile long and dozens of medications that are all working to counteract the effect of another medication. And then that's usually our job, is where we sit in the middle between other specialties of trying to make it all make sense. And it often doesn't make sense. So I think listeners may be asking and wondering, so what is it? What is that magic that's going to treat all three of those? And
Right.
we don't have that magic pill yet, but there certainly are some that you'd say, like, take opioids, for example, treating pain. All right, so we're just an opioid to treat pain, but the negative effect is that it causes all these gastrointestinal issues, not to mention a number of others. But if we're looking at treating pain and EDS, there may be some medications that may also be useful in the case of POTS or mast cell activation, and vice versa. If we're treating mast cell activation, then there may be some that we've learned from with time. So, for example, we take something like low dose naltrexone, where we see that there is overlap between at least two of those, between mast cell activation and pain potentially. So that's just one among other examples. Maybe this is another show too. We talk about just treatments in general, but we have to be careful. Certainly with other conditions, though, too. Beta blockers, for example, would maybe first line in many cases for POTS, but they can be exacerbating asthma issues too, and some other POTS treatments that may make mast cell activation worse too. So I think that's how we link it up, and I think that also we have to think about any one of these. Again, take mast cell activation. If we're going to treat that, we think about the other systems that could be affected with mast cell activation. We're treating mast cell activation, but we may not think it's affecting the gut. And then, all of a sudden, IBS improves. So I think if we keep kind of a wide net of what may be related when we're considering an approach to treatment, I think that's useful, because then we can potentially target multiple outcome or multiple conditions for a good outcome.
Yeah, I'm so glad you brought up about in case people are thinking, oh, we know about some magic pill that they don't know about. So yeah, we're going to talk about treatments in a couple of episodes. I agree. I love low dose naltrexone. It's something that I prescribe a lot. People have heard me talk about it a lot on the podcast for sure. And when it comes to prescribing, and you talk about the internist nightmare of so many different medications, the de-prescribing, right? The weaning off and stopping things. We don't get training in that, right? And I remember one of my guests quite a few episodes ago, Dr. Heather Tick, she asked me, she said, how many lectures do you remember from medical school on de-prescribing?
Right.
None.
Hey, none. Yeah. And that's the thing about it, is that there's not a lot of investigation into it, right? A lot of the trials and studies are into the effects and benefit of the medication, not like, oh, what do we do now? It's no longer needed. What does it look like? And what's the use of a trial stopping a medication for a pharmaceutical company? They don't want you to stop it. They want you to keep going.
Right. We talked about this a little bit earlier, but when it comes to conditions that can commonly masquerade as one part of the triad, are there certain things that come to mind?
Yeah, I think that that's a very good observation that a lot of these things do overlap. So the first thing that comes to my mind is that we have to stick with first principles. When I say that, it's what we have at our easiest disposal of guidelines and criteria that are already established, and they're not perfect by any means. But they're there, and they're there as at least as a starting point. So this is when we just kind of go through diagnostic classifications and criteria, whether it's HEDS, or HSD, or criteria for IBS or for POTS and things like that. It's there as giving us a starting point of what may be truly involved. Now, having said that, as really keeping the best interests of the patient up front and center, I will still consider potential treatments for someone if they're, half a point off the scale of a criteria, right? And this is where the art of medicine comes into play. And so we have to use our best clinical judgment, and the best clinicians have good judgment of how far do we go outside of the borders, or differences between one patient and the next, because there may be a lot of differences. And there's certainly a lot of differences between patients when they're developing this criteria to begin with. So that's what makes it a little bit cloudy. But having said that, I guess it just goes back to answer your question, that we just need to keep open-minded about what someone may be presenting with, and what may actually benefit them.
We know that it's so common for people to come in with a review of systems that's positive in multiple different systems, right? How do you decide what to address first?
Oh, well, this is a very good question, because uh, this was a question that was asked at one of the EDS conferences 2 years ago, and I gave a whole talk on it, actually, of how do you prioritize symptoms, really. The first way is, whether it's emergent or non-emergent. That's the first thing. Like, is this something that's, we need to address today, tomorrow, or maybe even within hours? And it may not be something that someone even is aware is a symptom that is urgent. Luckily, we don't see those so often, and usually it's because our patients are pretty well educated enough when something is emergent that they seek help urgent, and get to the emergency room or wherever they need. But the next step beyond that, what I would say is the other approach is based on what is affecting you, what is impacting you the most. Okay, so this is a more chronic condition. Then and maybe just in your own words, what is affecting you from doing the things that you enjoyed doing, or that you previously enjoyed doing? And then you can get any number of answers that may be related to different things too. Maybe sleep, or maybe back pain, or it may be headache, and and then we have to kind of go down a rabbit hole for a little bit, talking about that headache and characteristics of the headache and when does it happen. But that's what I would say as far as coming in to the doctor, and thinking about where to start and what are the issues. Well, let's start with what is the most pressing concern. What is the biggest issue that may actually tease out other things? But let's start with that one.
And in terms of what clinicians tend to miss, what are some subtle red flags that should prompt clinicians to look deeper?
I love the description of red flags, although I think that when I was first in medical school, and learning about red flags, they were related to back pain, and it stuck with me. And now that I've come to recognize other red flags for other conditions, it's like I've got so many red flags out there now. I need to start coming up with other names for them. But they are the things that we would be concerned about that could impact someone's life the most, whether it is an emergency or whether it's increased morbidity or mortality. And so when we talk about EDS, I mean, we can talk about any number of these conditions, mast cell or POTS, and they've all got their own red flags. For mast cell, it'd be like anaphylaxis. And for POTS, it would be, arrhythmias that can, they can be fatal. And then for EDS, usually what we're talking about are genetic red flags, where there may be concern for something that is identifiable with genetic testing, that may be something that is inherited, potentially passed on among other family members who may want to know as well, and may be related to different treatment planning as far as surveillance with imaging and other testing that may be useful to help, again, to avoid further complications.
And you're right about the abundance of red flags. So maybe a yellow flag might be the saying, if you can't connect the issues, think connective tissues. So when you have somebody sitting in front of you and they're reporting problems in multiple different systems, you mentioned Occam's razor. What could possibly explain the bulk of these symptoms, if not all of them? Well, right, it has to be something that's system-wide. So connective tissue, I mean, all three of those, right? Connective tissue, which would be the EDS or HSD, that could explain system-wide problems. Dysautonomia is clearly system-wide, controls your cardiovascular system, your GI, et cetera. And mast cells, we know, are everywhere as well. So I think that's another piece of that. Yeah.
Well, I'll just add to that because, I think that's absolutely right. And I think what we have, as I mentioned earlier, recognized with some time that we're learning about these associations of things is that, well, and to the benefit of patients, treating each of those that we can, and they may have different treatments. That's something to also keep in mind. And I will, venture to say that, as much as we can do to try to narrow it down, there is we'd love to challenge each other in residency, although there is Occam's razor to narrow it down. There's also Hickham's dictum that said a patient can have any number of problems as they please.
Yep.
And
Yep.
and it's true. And so that's why, as much as we want to link EDS and POTS and mast cell, and maybe there still is yet a single common pathway that one of those is causing the other. We just haven't recognized it yet. So we need to recognize that all of those may be potentially there, and they all, in some ways, may have different treatments. And we need to, again, like we're trying to provide the best treatment to patients, we need to address all those things that we can.
I'm glad you pointed that out because that is definitely something that happens quite commonly once someone does have the EDS diagnosis, or even if they suspect it, right? Then they start writing everything off to that. But you're right; they're entitled to other diseases too, so they definitely can have other things going on. So that's an excellent point. Thank you for bringing that up. And I will also link to the show notes, the red flags document that I have on the Bendy Bodies podcast website so that people can see, like, these are the things that should really make us think about doing genetic testing for some of the more rare types, because I'm really glad that you pointed that out as well. And speaking of labs, why do normal labs and, normal or, unremarkable imaging results, why are those so challenging?
Well, let's say, I guess let's start from the beginning, why we might order imaging or labs to begin with. And the obvious answer is because we don't know what's going on. And some of those most common situations where we don't know what's going on, let's take what I had mentioned were the most common presenting complaints, pain or fatigue. So those can certainly warrant imaging and lab tests. To answer your question, why the labs and imaging tests may be confusing is because there is not any specific lab test that we can use to say that someone's in pain, right? We can't justify someone's pain with a lab test. And so I think it catches patients in a difficult situation where they may have normal lab tests and they're told that, like, well, you don't have any reason for your pain, right? And I mean, how much worse can you get as far as if trying to get any clarity on what you're suffering from? So that's I think the first issue, and the biggest issue, and probably the most common issue for our patients. But the next issue is that if there are some lab abnormalities, and okay, so it's good if there's a lab abnormality, we can identify a diagnosis and it's clear. And let's say it's an autoimmune disease, rheumatoid arthritis, and we can diagnose this with imaging and lab tests, and we can get them on some very good treatments nowadays to resolve and decrease the duration of symptoms. Uh, but there's also a possibility that these lab tests are abnormally abnormal, or what we would call a false positive. And then this leads us down the wrong path of treatment and just delays, costs more, and ultimately doesn't serve us well. So, again, back to the art of medicine issues, we have to think about the condition that the patient is in, what they're presenting with, and then what are we actually looking for? What are these labs going to tell us or not tell us? And then, use our best judgment what may be useful or not. I'll use a quick example, not to drone on too much about it. Well, I could talk about this all day because of what I do every day. But one of the screening tests that we use for autoimmune diseases is the ANA, so an anti-nuclear antibody. And it's a very good screening test. And as the screening test goes, we want to catch all those diseases and potential cases that we can. Doesn't mean that it has a high specificity for any one disease. It just means that there's more likely a chance that we're not going to miss something. That's what we want for a screening test. We want to not miss. But because it may not be very specific, and ANA is one of those among other tests too, it can lead to false positives. So we have a lot of patients who would say, my ANA is abnormal, and they get concerned about it. And it's like, well, okay, that's the reason why we do those other autoimmune tests and for other autoimmune diseases and other labs that may be related to lupus or rheumatoid arthritis and and Sjogren's and so forth, because the ANA can only get us so far. It sort of just opens up the door, but often it just does add to extra anxiety. And that's certainly part of the complication of imaging and lab tests, is you ask that abnormal results will certainly bring patient anxiety. So we have to be ready to answer questions that may come up related to those.
Yeah, definitely. And we can't see someone's pain on imaging. So, you can have imaging that, like my mother's hands, before she passed, she had this horrible, horrible arthritis. She had less pain in her hands than I have. But the imaging does not tell that part of the story. So yeah, and it can be definitely really challenging for people. And I had a patient come to me once who traveled a pretty good distance to come see me, and basically she was not hypermobile. She knew that she probably wasn't, and so she wasn't even like, I wasn't worried about a connective tissue disorder for her, but she had chronic pain, and basically all I did for her was tell her, look at her imaging reports. I didn't even have the actual images, but I said, you have plenty of reasons to have pain, and she started to cry. And she was like, "I do?" And like that was like totally worth it for her. She was like, nobody had told me that. I was like, "Yeah, no, you have all these things that are going on in your body." And so, yeah, I think oftentimes we just, like you said, words matter a lot, and we should pause and think before we speak. Speaking of pausing and thinking before we speak, we want to give some takeaways for clinicians, so and for patients also. But are there some questions, like maybe 3 questions that every clinician should ask when a patient presents with symptoms that span multiple systems?
Yes, there are. And so the first thing that I would say, and just to think about your patient example there too, is that, and I presume in her case that she was told that everything was okay. Is that right?
Hmm.
In her
Yep.
past, and yet she still was trying to emphasize that something's not right.
Right. And I think what happened was, probably there was nothing surgical. this has happened to me. If there's nothing surgical, then I think some, orthopedic surgeons, maybe in particular, might be like, either imply or say, you're fine. But it's like, no, you have pathology there, and that explains your pain, but there's just nothing for me to operate on.
Yeah, exactly. And I encounter that all the time too. And different systems have different approaches as far as what they will see. And sometimes surgeons will see patients for conditions that may not need surgery, but they're knowledgeable about, and that's ideal because obviously surgeons have a lot of knowledge and experience of treating not just surgically, but knowing about the conditions that they treat. I think that this is, as a starting point, this is a good example because as a starting point, a clinician could get at least an understanding and ask, you know, as I mentioned earlier, letting the patient talk, what is the most bothersome thing to you? As a starting point, right? And that's not going to get them all the way there because, as you just pointed out, the patient told them that and didn't really seem to go anywhere. So, but for a clinician, at least to grasp, what is really up front and center. Uh, Beyond that, and of course, we have the whole mnemonic of we call Socrates. So, is this something that's related to different organ system? What is the onset, timing, duration, radiation, presentation of different symptoms, and things like that? So they can certainly kind of navigate from there, from what is the presenting complaint, to get more characteristic features. But I think that the next thing that the clinician would do well to keep in mind is an understanding of what the patient has gone through to get to them. And I think that's very telling. And I think in the case of our patients that have gone through so much that I mean, that's a answer as clear as day that, there's something unusual that I can't use my standard algorithm here for. I can't use, the specific textbook. I've probably got to think a little bit more creatively here. But those two questions are at least a very good starting point. Most bothersome, and what have you done to get here? And that's how I like to start all of my visits. What I would say, probably, again, to keep the patient's experience up front and center, and keep their goals of care, as we talk about shared decision making, models of care where we are moving in years to less of a kind of paternalistic approach of I'm the doctor, I'm telling you what to do, now do it. But getting an understanding from the patient what may be the best treatments for them, for the time and place that they're in, for whatever the job they're doing, what kind of life they're living. I think the next question then relates to that and is, what are your goals of care? What do you want to see improve? So, yeah, I think that that's a good kind of basic approach, but there's obviously many hundreds of questions that can be tied to all of those.
And for patients, how can they describe their symptoms in a way that clinicians are most likely to listen and understand?
Yeah, this is another excellent question that is, I think, something that gives patients a lot of hesitation and nervousness about seeing doctors to begin with, and no fault of their own because they've you know likely been on a long journey. They've possibly been misguided and misdirected, and so I think the best starting point is to have an understanding ahead of the visit, kind of 1, 2, and 3. These are the specific items that I want to make sure I address. And I have patients who come in with notes on their phone or written out, and I love it. It's great because it gives me the sense that at least they'll have a peace of mind. At least we covered those things, even if they, can't think of all the questions at the time of the visit. At least they get those out there. So I love it when patients do it. I highly encourage that. We don't need to burn the midnight oil. We don't need to lose any sleep over it, but at least jot some notes down, and it will really, I think, serve you well.
Well, this has been a great conversation. As you probably know, I like to end every episode with a hypermobility hack. Um, do you happen to have a hack to share with us? If not, I have a hack for clinicians, but if you have a hypermobility hack, that would be great.
Well, Yeah, my last one was to trust your gut. So
Mm.
I don't want to uh, use that more than I should. So I'd love to hear your hack.
Okay, well, the funny thing is your hack and my hack are very closely related. So,
Perfect.
yeah, yeah. So my hack is for clinicians, and I think that when you are seeing a patient and you've gone through, your like you said, listening and trying to get a really good sense of what's going on, I think that it's very reasonable to ask the patient, "What do you think is going on?"
Absolutely. I love it. And I think they may be surprised is that they may have a more informed answer than they expected.
Right. Right, right. And I had one of my doctors, a neurosurgeon, ask me once, "What are you most afraid of, or what are you most worried about?" And I think that's a great follow-up question to, what do you think is going on?
Right. And that probably leads into a better understanding for them of what the patient wants to get out of their care. And we can do that in a shared decision model, and it's best for everyone.
Absolutely. And I think too, when you do that, allowing the person to verbalize what they're most afraid of, allows us to kind of address it at least. And like you said, when they come in with that list of questions and, because we know that we're not going to cure people. It's not like when they leave, they're going to be pain free. The goal is to improve their quality of life and their functional capacity and everything like that. But, it's really helpful when they do come in with those questions. And if, as the clinician, we've asked those two questions, then I feel like that really gives the person the opportunity to air that. And, they might be afraid of something that, we can actually say, I feel very confident that that's not the case. For example, I'm sure you've had this happen a lot. They're really afraid they have vascular EDS, and they might be 70 years old and they have no signs at all of vascular EDS. And so we can reassure them that, this does not look at all like vascular EDS. Plus you're 70 years old. So by now we would really, have a good idea about that.
Well, we can see that, that's a great example where just being of service to the patients to listen and answer questions to begin with is a huge, part of what we do. And that's a very simple thing to do.
Yes, and we should be giving them at least that. Well, this was such a great conversation. I loved getting to spend the time with you. And before we go, can you just tell people where they can find you and where they can learn about the UVA EDS Center?
Well, yeah, I would love to have that out there. And we will obviously be on this podcast and all of the listening platforms it's available on. So look forward to staying connected there. And as far as the UVA Health Center, so we have a website. We'll make sure that those links are available in the notes, and then also a phone number. So we take self-referrals and we help answer questions, and then do what we can to see patients when that's available.
Well, thank you so much for taking the time to chat with me. I know that you're very busy. This is an exciting time over at UVA, and I just can't wait to see how the center evolves. And I love having these conversations with you. So I look forward to the next one.
I enjoyed it thoroughly as well. Looking forward to those as well.
Well, I'm so excited about having Dr. Knight here twice a month to co-host episodes with me and have these great conversations. Please do remember to submit your questions to bendybodiespodcast.com because we will be addressing as many of those questions as we can. So I really look forward to seeing what you want to hear us talk about. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at HypermobilityMD. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.